Alright, so I'm going to begin with Chapter 55, Care of Patients with Stomach Disorders. Gastritis is when there's inflammation of the stomach lining. Gastritis can be erosive or non-erosive. We also have different types of gastritis. We have acute gastritis and we have chronic gastritis. Acute gastritis is when there's inflammation of the mucosa after the patient was exposed to certain irritants. The membranes become thick and reddened, and they have prominent folds or rugae. Regeneration occurs within a few days with acute gastritis. With chronic gastritis, there's patchy, diffuse spread of inflammation. Atrophy occurs and the parietal cell's function decreases. Intrinsic factors also decreased, which can lead to pernicious anemia. Those individuals that have chronic gastritis are at risk for developing gastric cancer. There are different types of chronic gastritis. So we have acute gastritis and we have chronic gastritis. Chronic gastritis breaks down into type A, type B, and then atrophic gastritis. So type A gastritis, chronic gastritis, is non-erosive. Typically, it's associated with autoimmune diseases and has a genetic link. Type B chronic gastritis is erosive, and it can involve the entire stomach, not just parts, such as type A. Type B affects all layers of the stomach. Cellular changes or metaplasia lead to peptic ulcer disease and gastric cancer. H. pylori is typically the causative factor for type B chronic gastritis. With atrophic gastritis, that's another category of chronic gastritis disorders. It typically occurs in older adults. It can lead to gastric cancer and gastric mucosa-associated lymphoid tissue lymphoma, or MALT, M-A-L-T, lymphoma. It can be caused by toxic substances or by H. pylori. H. pylori, staph, strep, and E. coli can be causative factors that result in gastritis. Now, NSAIDs that are used long term, as well as alcohol use, coffee drinkers, patients taking in caffeine and steroids, all of those things can increase the risk for acute gastritis. Diet, exercise, and stress reduction all play a key role in preventing the development of gastritis. Alcohol and tobacco should be avoided for these patients. Now there's a chart on page 1128, chart 55-2. It differentiates acute versus chronic gastritis. Now when we assess these patients, we want to note tenderness or bloating of the abdomen. We want to know if there's hematemesis. We want to know about melena. We want to note if the patient has experienced food poisoning with nausea, vomiting that occurred within 5 hours of eating the food. EGD is performed to diagnose, and a biopsy is performed. Interventions. Acute gastritis is typically just treated by the symptoms, so it's treated symptomatically. Surgery may be needed for those with bleeding or ulceration of the stomach. With chronic gastritis, individuals include treating the cause as well as healthy lifestyle teaching. Drugs given, we have H2 receptor antagonist, and those are the antacids. We have proton pump inhibitors, or the those ending in azole, azole. And then we have vitamin B12 for those with chronic gastritis, because remember, they're no longer able to produce that intrinsic factor, and without intrinsic factor for vitamin B12, these patients suffer from pernicious anemia. Now, peptic ulcer disease. With peptic ulcer disease, mucus defenses are not able to protect the epithelium from acid and pepsin. There are 3 different types of peptic ulcer disease. We have gastric, duodenal or duodenal, and stress. Now, gastric, this is when there's a dysfunction of the pyloric sphincter with bile backing into the stomach. The pain is typically localized left of the midline and aggravated by food. The duodenal or duodenal peptic ulcers, these have a high gastric acid secretion. They're located right beside or below the epigastric area. Typically, the pain occurs 90 minutes to 3 hours after eating. The pain can awaken the patient at night with duodenal ulcers, and certain foods make the pain worse. Now, with stress ulcers, there are multiple shallow erosions of the stomach. Patients with extensive burns and increased intracranial pressure are at risk for stress ulcers. There's a table on page 1132, table 55-2, and that lists gastric versus duodenal ulcers if you need a visual. Most peptic ulcers are caused by H. pylori, and our body's own natural defenses activate, which then cause cell necrosis. Because remember, H. pylori is a bacteria, so our body's natural defenses are going to try to get rid of that, and that's what causes cell necrosis. Now, complications from peptic ulcer disease, we can see hemorrhage, perforation, and pyloric obstruction. With bleeding, the individual can vomit bright red blood or a coffee ground emesis. Hematoemesis indicates upper GI bleeding. Digestion of blood can result in a black or a darker color stool. Perforation happens when the wall is worn away. So when contents leak into the cavity, sudden sharp pain occurs, and it's typically over the whole abdomen. The abdomen becomes rigid and board-like, and rebound tenderness occurs. Typically, you'll see patients assume the fetal position because that helps with tension. Peptic ulcer perforations are emergencies. Now, pyloric obstruction, that can occur and it results in the patient vomiting. The obstruction is typically caused by scarring, edema, or inflammation. The patient will have abdominal bloating, vomiting, and possibly even suffer from metabolic alkalosis or hypokalemia from the vomiting. Peptic ulcer disease, typically caused by NSAIDs and H. pylori. Patients undergoing radiation can be at risk for developing ulcers. We want to make sure the patient is able to identify any certain foods that aggravate their symptoms. And we want to note any history of H. pylori infection. Now, review all of the over-the-counter medications and the prescription drugs that the patient's taking whenever you're doing a history intake. You want to know that if pain is occurring when their patient's eating, or is the pain occurring at night when they're sleeping? Are they waking from the pain? Are there any changes in the pain? Where's the pain located? Indigestion is a very common symptom that is correlated with peptic ulcer disease. Appetite is typically not affected with individuals that suffer from peptic ulcer disease unless there's an obstruction. Now, you do want to assess for fluid volume deficit in these individuals in the case that a presence of blood loss is suspected. Now, laboratory assessments, H. pylori can be detected in the patient's blood, breath, or stool. As far as imaging, if perforation is suspected, then imaging will be ordered. Nursing diagnoses, typically pain related to ulceration and upper GI bleed related to perforation are common nursing diagnoses for these patients with peptic ulcer disease. We want to make sure that we're controlling these patients' pain, eliminating any infection if present. We want to heal the ulcers, and we want to prevent more ulcers from forming. Okay, these are all take priority. If H. pylori is present, proton pump inhibitors and 2 antibiotics for 10 to 14 days are typically prescribed. Proton pump inhibitors are the drug for patients or individuals with acid-related disorders. On page 1133 and 1134, you should look over chart 55-4. This should be a review for you. Now, bland diets are recommended, and food before bedtime is avoided for these patients. Complementary therapies can be those such as cranberry and probiotics. For a full list of those complementary and alternative therapies, you can see table 55-1 on page 1129. I will begin in the next audio clip.